Dr. Enriqueta Felip, coming from the Vall d'Hebron Institute of Oncology, and she will deal with the news in other oncogenic drivers, NTRK, BRAF, and MET.
Thank you, dear chairs. I would like to thank Dr. Delvis and also Charo, Luis, and Stephen. Thank you for your kind invitation, my declaration of interest. So I'm going to discuss three actionable genomic alterations that are really uncommon. When we analyze the percentage, MET exon 14 is present only in 2% of the cases, BRAF V600 in 2%, and NTRK fusions in 0.3%. And the reality is that the agents that we have approved in these three alterations are only based in phase 2 trials. So I'm going to start with MET. There are different pathways for activation, for aberration of MET, exon 14 skipping mutation that I'm focused, but also there are tyrosine kinase mutations, amplification as a mechanism of acquired resistance in patients with EGFR. I will not focus on that. We can see fusions, and perhaps protein overexpression may will be important when we discuss ADCs. But mainly focus on exon 14 skipping mutations. The clinical characteristics of the patients with these alterations are slightly different. This is an older population. The majority of patients have 70 years old. Equal gender distribution. There are a percentage of patients that are smokers. And we can see in the tumor high PD-L1 expression, but low TMB. And we all are aware that we have two MET tyrosine kinases approved, capmatinib and tepotinib. I'm going to focus only to review the latest data with this compound, capmatinib, that was based, the approval in the phase 2 Geometry Mono 1 trial was updated and published in Lancet Oncology 2 years ago. And for the group of patients treatment naive, the response rate with capmatinib was 68%. The median progression-free survival was 12.5 months. Very similar results with tepotinib that was updated also during the ESMO meeting, in this case in 2025. For those patients treated in first line and for whom the analysis of MET exon 14 was in tumor biopsy, the response rate was 54%, and the median progression-free survival was 13.7 months, with a median overall survival of 22 months. So these are the two agents approved. There are some subset analyses. It seems that these agents are also active in CNS, although the majority of patients included in the trial had previously treated brain metastases. So the situation is different in the States and in Europe. In Europe, we have the approval of tepotinib and capmatinib for those patients with MET exon 14 skipping mutation who require systemic therapy following prior treatment with immunotherapy and or platinum-based chemotherapy. So it's in the second line. And this is perhaps the controversy. So in the first line setting of these patients, we don't have any randomized trial comparing chemo plus immunotherapy versus TKI. We can discuss if we decide to give first line chemotherapy, if immunotherapy is needed. I can say that in my approach, I treat these patients with chemo plus immunotherapy, but we can discuss. And this is the difference that we have. In my personal view, I would be more comfortable to start treatment in first line with a MET tyrosine kinase inhibitor because the response is more quick, and perhaps the toxicity, if we start with immunotherapy and then TKI, will be worse. But this is the situation that is different in States versus Europe. There are other agents in the MET exon 14 skipping mutation. Savolitinib was also analyzed in a group of patients in China. 125 patients, treatment naive and treated with savolitinib with a response rate of 62%. And we have learned also that ensartinib is also a MET inhibitor, and the EMBRACE study included patients with MET exon 14 skipping mutations previously treated, so it's a second line scenario. 31 patients were included with a response rate of 53%. Amivantamab, a bispecific antibody, has been also analyzed in patients with MET exon 14. This paper was published this year, although it was previously presented in a meeting. There are different cohorts of patients with MET exon 14. There are 16 patients treatment naive included. The response rate was 50% with AMI. There are 28 patients previously treated, but without MET inhibitors. In this group, amivantamab was associated with a response rate of 46%, and for those patients with prior MET therapies, 53, the response rate with amivantamab was 15%. So probably there is a role of sequence with amivantamab after MET exon 14 skipping mutation inhibitors. Only one slide about Teliso-B, an ADC targeting c-MET. We have seen in the previous year the results of Teliso-B in patients with non-squamous EGFR wild type and MET overexpression by immunohistochemistry with a response rate of around 20%, 25%. And the reason to include the slide here is because there is a randomized trial now in second line in this group of patients, non-squamous, c-MET overexpression, EGFR wild type, comparing Teliso-B versus docetaxel. And the new agents, and this was presented during the ASCO, is a new ADC, MET+NSCLC, and the reason is because mentioned that is a novel ADC that is pH dependent, and this pH dependent results in a preferential delivery of the drug to the lysosome. So these authors presented results, and the activity was seen in patients with, even with MET expression low, with a 36% of responses, and also in patients with previous taxane therapy. So this is the summary slide for this part, that are the clinical practice guidelines that are living guideline was updated in January 2025. So for those patients with MET exon 14 skipping mutations, the first line treatment options is still MET TKI, capmatinib or tepotinib, or platinum doublet chemotherapy, in my opinion, together with immunotherapy, and a disease progression, the other treatment. If first line chemo plus immuno, MET TKI, and if first line MET TKI, chemo plus immuno. Let's move on to BRAF. BRAF B600, that is the alteration that we can target, represent 40% of all BRAF mutations. Age 60, 70 is not also the typical EGFR, ALK, or ROS, or RET mutation. Equal distribution, we can see the alteration in smokers. And we know, and we knew that there is a need for dual MAP kinase blockade. And you all know that dabrafenib plus trametinib is one of the standard of care in patients previously treated and in patients treatment naive. And in both groups, the median PFS with this combination was similar, 10-month median PFS, an overall survival of around 18 months, and there are 5-year overall survival of around 20% of the patients with this combination. We have to manage the toxicity and perhaps highlight the pyrexia with this combination and asthenia. But there is another combination that is encorafenib binimetinib based on the PHAROS-2 trial, and it was a first presentation that showed that for those patients treatment naive, 59, the response rate was 75%, and the median progression-free survival was not reached. The results were different in patients pretreated, 39, in which the response rate was 46%, and the median PFS was 9 months. And there is also the ENCO-BRAF study from the French group in treatment naive, receiving the same combination. Here, the response rate is very similar, 65%. The median PFS is shorter, 10.9 months. However, again, the median overall survival was not reached. And during this year at ESMO meeting, there was the updated information of the PHAROS study in patients treatment naive, 59, receiving this combination with this objective response rate of 75%, median duration of response amazing of 40 months, and median progression-free survival of 30 months. And also, the overall survival was presented, and in this presentation and publication, the overall survival, the median, was 47 months. And although it's impossible to compare toxicity between different trials, perhaps we can see that the pyrexia seems lower with this combination when compared to the trametinib. So again, in concluding this part of BRAF V600, I think, again, no changes about what the clinical practice guidelines ESMO mentioned for those patients with stage 4 and BRAF V600 mutation. The standard of care, I think, in this case is clear because it's approved by FDA and also EMA, is the combination of DABRA plus trame or encorafenib plus vinimetinib, and a disease progression chemo plus immuno. The ESMO guidelines mention that perhaps the second line will be decided based on a tobacco use. And for patients with a smoking history, clearly chemo plus immunotherapy should be a standard of care. Finally, NTRK is still more difficult, NTRK, because as we mentioned, 0.3% of non-small cell lung cancer have this alteration. So this is uncommon. We can discuss how many patients we have seen, but you know, it's really uncommon. The most frequent fusion variant is NTRK1 in 0.12% of the cases. And you have seen this slide several times. And when we discuss larotrectinib, there are 32 patients. And this was updated at ASCO 2025. The previous one was 30. So it's really uncommon. 32 patients included, 12 patients with brain metastases, and this analysis presented by Dr. Tan at ASCO, the response rate was 69%, the median PFS 22 months, the median overall survival 41 months. With entrectinib, again, there are 51 patients with lung cancer, 20 patients with brain metastases, 63% response rate, intracranial overall response rate of 67%, median PFS of 28 months, and median overall survival of 41. There are different toxicities with larotrectinib and entrectinib. Perhaps to recommend this review paper by Dr. Repeto from Memorial. And we have also data with next generation NTRK inhibitors, and perhaps the most mature data is with repotrectinib that was presented by Dr. Solomon during the ESMO meeting and in 2023 and included two different groups of patients. One group of patients, TKI naive, 40 patients. In this group, repotrectinib was associated with a response rate of 58%, and the median PFS was not mature. And there was also a group of 48 patients previously treated with TKIs. In this group, the response rate was 50%, and the median progression-free survival was 8.6 months. There are other agents. Taletrectinib is also an NTRK inhibitor, although the literature with taletrectinib and NTRK is rather small. I have seen 1 or 2 cases, but in theory, it's NTRK inhibitors. And there is a drug that is surletrectinib that is also, and we have some results, that is a novel, potent, next-generation NTRK inhibitor with a strong intracranial activity. And during ASCO 2025, 2 trials presented with surletrectinib in patients NTRK. The first one is in pediatrics patients and adolescents in first line, not in first line. There are different patients in first line, but patients also previously treated, and included 18 patients. 6 were previously not treated, so treatment naive. And the response rate in these 18 patients, the majority previously treated, was 100%. And then also at ASCO this year, there was a presentation of this agent in first line in patients with NTRK, and the response rate in this case was 84%, and a median progression-free survival was not reached. So again, these are the clinical practice guidelines from ESMO that really define the standard of care in this population. And for those patients with NTRK, we have 3 options at present as first line: entrectinib, larotrectinib, and perhaps if we don't have access, platinum doublet chemotherapy. But at disease progression, I think entrectinib or larotrectinib should be given, if not been previously given to the patient. And at disease progression, we have repotrectinib. And perhaps the discussion is how we can change the treatment in this case, in this group of patients, by next generation NTRK inhibitors. And thank you for your kind attention.